Um, so hi everyone. Good for you for either giving up and staying home to get to Grand Rounds or slogging through the 20 centimeters of snow to get to wherever you are for rounds. Swapnil is still in India, so I'll be your host for today. And we have Dr. Matthew Graham Brown with us. He's a clinical associate professor of renal medicine, despite working in the cardiovascular realm, so we won't hold that against him too much. At the University of Leicester and is an honorary consultant nephrologist at the University Hospitals of Leicester in the United Kingdom. As I suggested, his research is focused on cardiovascular disease and chronic kidney disease, and particularly in the role of advanced imaging to identify clinically relevant pathology and in testing lifestyle innovations that might improve cardiovascular health. He's been working on the implementation of evidence-based practice, particularly with all the introduction of new options for us, the optimization of lifestyle and pharmacotherapy in early stage chronic kidney disease and in cardiovascular renal metabolic conditions. So he'll be speaking us about what to do with the foundation therapies for heart failure in end stage kidney disease. So that'll be interesting to hear, see if we can move the needle in that very challenging population. I'll turn it over to you, Matt.
Thank you very much, Dr. Kapinski. I thought when you said Associate Professor of Renal Medicine, I was going to be a comment about the word renal versus kidney, which would be fine, I'm having. But I know there's...
I'm old school. I still say end stage renal disease. So yeah.
It's interesting how language evolves, isn't it? I like the word renal, but I know some people are very anti, and there's no problem with that. So thank you very much to the department for the invite to speak to you. I hope today is useful, and I'm not going to claim up front to know all the answers or to be in any way preachy about what to do, because this is a really, really tricky area, and there's lots of things that need to be considered for different types of patient. And as is the case often for kidney medicine, renal medicine, we don't have a tremendous evidence base on which to base our practice. So we have to work with what we've got and apply safe and thoughtful processes when we're thinking about the patient in front of us. So just to go through what I think we'll do this morning for you, is we'll look at the scale of the problem in terms of the prevalence of the different heart failure syndromes in end-stage kidney disease. We'll think a bit about why those patients get cardiovascular disease generally, and why that's a different version of cardiovascular disease to what we might be used to thinking about in the general population. We'll look at the guidelines as they are and the underpinning evidence as it is to see how we can plot a course forward. And then we'll hopefully come to some sort of consensus around what best practice looks like for this difficult to treat population. So those are your disclosures. These are mine. The ones that I think are relevant is I do have some speaker honoraria from some pharmaceutical companies, and I'm the current editor of a website called Renal Reviews, for which I received an honorarium from OmniaMed Publishing Company. So just to start, cardiovascular disease it's a great big problem for patients with advanced kidney disease. And I looked on your Canadian databases for Canadian data, and I couldn't find any. So if I've missed it, apologies. But this is UK data on the cause of death for adult patients on in-center hemodialysis up to the year 2022. And here are I don't know if you can see my mouse, but the pretty much stable throughout. The red line here is death from cardiovascular disease, which is between 20 and 25% of all deaths. Of course, there was this lump during 2019 where some infectious disease that we won't mention came along and caused a lot of problems. But actually, the trend is back towards the 25% of deaths in the end-stage population caused by cardiovascular disease. And if you look at the US RDS database, that number is actually rather higher. It can be up to closer to 40%. And it's a different type of cardiovascular disease to the one that we're usually talking about or we learn about at medical school. And it's to do with clustering of different types of risk factors. Yes, the traditional risk factors for cardiovascular disease, your high cholesterol, diabetes, hypertension, are overrepresented in populations of patients with chronic kidney disease. But they also cluster with some very disease-specific problems for this population. So chronic kidney disease generally is a chronic inflammatory state with all of the cardiovascular complications of that. Our patients are anemic because of erythropoietin deficiency and iron deficiency. Proteinuria of itself is an independent cardiovascular risk marker. The associated complications of uremia, the kidneys obviously hugely important in bone mineral metabolism, and lots of our patients are deficient in vitamin D and active vitamin D. The endothelium is highly activated in advanced CKD, which causes huge problems with perfusion of capillary tissue beds. And crucially, dialysis, whilst it is a good therapy to keep people alive, it is involved directly in driving adverse cardiovascular outcomes, pathological changes in cardiovascular disease and heart failure in the prevalent population. The relative contribution of traditional or non-traditional risk factors does change as you move from early stage CKD to advanced stage CKD. And as you obviously progress towards end stage, the influence of the non-traditional risk factors becomes more and more important in changing the driving the pathological changes that occur. But it's important to remember that occurs on a background of these highly prevalent traditional risk factors. So whilst the aim of this talk is not to talk about early stage CKD, lots of the work we need to do in treating cardiovascular disease generally happens upstream in the prevention, and it happens along with a cardiovascular renal metabolic strategy for reducing people progressing to end stage, optimizing cardiovascular therapies, treating metabolic disease like diabetes really, really well. And then when you get that group of patients coming through, hopefully as a reduced number will be reaching end stage, but also when they reach there, they have been better treated to that point. So they're a healthier population. But that's a different talk. You can invite me back next year to do that maybe. Some people don't like the term uremic cardiomyopathy. I think it's quite a good term. It refers to the stereotyped pathological changes that occur, particularly in the left ventricle, that associate with the advanced and end-stage kidney disease population. And it's this collection of different things. So the presence of left ventricular hypertrophy, usually along with left ventricular cavity dilatation, the problems you get with aortic and arterial stiffness through arteriosclerosis, that's medial calcification of the arterial circulation, and all of those processes coalescing to cause the pathological problems of myocardial fibrosis. And each of those individual components of uremic cardiomyopathy are known to associate with adverse outcomes for patients. But if you had to pick one that you said, I want to get rid of that one forever, it would be myocardial fibrosis. And when you think about myocardial fibrosis, it's easy to think about the fibrosis that occurs after an acute coronary event. So someone presents with an acute coronary syndrome, there is death of myocytes, and that's replaced by scar tissue. And it's easily seen on imaging with thin-walled myocardium that doesn't move very much. But actually, that's just one version of myocardial fibrosis. And actually, it can be driven by infiltrative processes, which you can see here, like amyloidosis or Anderson-Fabry disease, where proteins or glycosphingolipids are laid down in the extracellular space, causing expansion of the extracellular space, which then increases the distance over which diffusion has to occur for oxygenation and for waste removal. which can lead to ischemia and then lead on to myocardial fibrosis. But it can also be a reactive process that's caused by hypertension, diabetes, and kidney disease. And that's a similar sort of phenomena. So the collagen fibers get laid down in the extracellular matrix without coronary artery disease being present necessarily. And that expands that extracellular matrix and causes those same problems with tissue perfusion. And we've got very good, although quite old now, histopathological studies showing that as stage of CKD progresses, degree of myocardial fibrosis gets worse. It's worst in dialysis patients, but it does recover following transplantation. So it's something that's it is potentially amenable to intervention, and particularly early intervention. And almost all patients who have heart failure, which is what I'm supposed to be talking about, will have a degree of myocardial fibrosis. And when we talk about heart failure, in the olden days, we'd think about pump failure. We'd talk about patients who had reduced ejection fraction, typically less than 50, and that would be seen to be abnormal. But heart failure nowadays is a much more dynamic state. It's much more thought of in a much more dynamic way. And so you've got patients who are identified as being at risk, and patients with kidney disease, patients on dialysis are definitely at risk. And they might progress through the different stages from preserved ejection fraction to moderately reduced ejection fraction to reduced ejection fraction. But what's also true is that if you can limit the impact of comorbidities, if you can treat heart failure well, or if you have a profile that means you are disposed to have better outcomes, then you can actually move back up the ladder as well. So it's a dynamic situation. And that's certainly the case in the end-stage population, as we'll see. So I hope you're familiar with those terms, the HFpEF, HFmrEF, and HFrEF. And they are part of a much more wider and more universal definition and classification system that we use now for talking about heart failure. So the classification, as I've just referred to there, is you've got your patients with reduced ejection fraction, that's an LVEF of less than 40%, moderately reduced, where it's 41 to 49, preserved, which is above 50, but with structural changes or hormonal changes that would be consistent with heart failure. And then we also talk about improved ejection fraction. That's people who've got better. So people who've got heart failure but may have gone into remission or might have improved their type. When we talk about staging, which is the middle column here, we are thinking about people who are at risk, people who are pre-heart failure, people who've got established heart failure, and people who have got advanced heart failure. And some of that's based on symptomatology with the New York Heart Association classification. But at the base of it all, we've got our definition of heart failure. And heart failure, as I say to the students every week when I talk to them, we do a case on nephrotic syndrome and they all think the patient's got heart failure. That hopefully isn't a surprise to anyone. The definition of heart failure is that it's a clinical syndrome, not a diagnosis. So if someone meets the right sort of clinical phenotype, they have signs and symptoms that are consistent with structural functional cardiac disease, and it's corroborated by elevated natriuretic peptides or evidence of systemic congestion, then they meet the definition for having heart failure. And we need to consider all of those different things when we're thinking about the diagnosis of heart failure. But it's more difficult in CKD because lots of those things that talk about how it's defined are tricky when you're talking about an end-stage population, because of course our patients are prone to fluid overload, they're prone to deconditioning, and lots of the symptoms of end-stage kidney disease related to overload and deconditioning mimic those of heart failure. And then we've got the way that we assess it objectively, a cardiac function objectively, with echocardiogram. Echocardiogram will estimate ejection fraction, and the geometric assumptions that it makes to do that are based on normal loading of the ventricle. And in states of volume overload, like end-stage kidney disease, like heart failure, like advanced CKD, echo will tend to overestimate LV mass and dramatically underestimate left ventricular ejection fraction. Similarly, our dialysis patients, if you did their BNP before they went on dialysis, they would all be raised because they're volume overloaded. And natriuretic peptides, of course, are released from the myocardium in response to stretch. So there's special considerations we need to give to how we are defining and diagnosing heart failure in this particular population. And we need to be thinking about doing all of these tests and assessing people when they're euvolemic, to get the best and the best idea of what their symptomatology actually is, what their echocardiographic findings actually are, and what their natriuretic peptides really are. So just some things to consider. So what are we looking at in terms of the scale of the problem here? What's the problem with heart failure and end-stage kidney disease? Well, here's some data from about 2006, 2007. It's based on USRDS data system data, looking at the incidence of heart failure for patients of different disease types. So the orange line here is hemodialysis patients, and it's no surprise to anybody, I hope, that as time goes on, your risk of developing heart failure goes up significantly. And these patients, this data was all censored for people who had heart failure when they started. So this is not prevalent patients when they started. This is the risk of developing heart failure once you're established in the orange line here on dialysis. The risk of developing heart failure if you've got a kidney transplant, that's the purple line, PD, the green line, and CKD, if you remain a CKD patient, the blue line. And again, it's just saying it out loud, really. Having heart failure is bad in terms of outcomes, but having heart failure and kidney disease is even worse. So here's some data from about 5 or 6 years ago, I think now, which looked at the outcomes for patients who had heart failure, whether that was PEF, REF, or MREF, comparing them to whether they had impaired kidney function or not. So this isn't patients on dialysis. This is patients with or without an eGFR of greater or less than 60. And the unbroken lines here are your patients without any kidney disease. This is their cumulative mortality going up over years. And if you have the same, essentially the same group of patients, but their kidney function is less than 60, their cumulative mortality at every stage is significantly elevated. And that's not talking about dialysis patients, that's talking about sometimes very early CKD. So having these things in combination, having CKD in combination with heart failure, is terrible for your outcomes. And if you've got dialysis, you can imagine it's even worse. So those are big population studies, and population studies can be criticized because we're not entirely sure about whether the coding of patients is correct or whether the outcomes are being recorded accurately. So I will just show you this, which is unpublished but is under review at the moment, which is an MRI study that we've done in Leicester with our colleagues in Glasgow, Paddy Mark, where we've put together patients who've been really, really well phenotyped with cardiac MRI and natriuretic peptides and symptomatology. And we've defined here, one of the things we've done is the classification of different patients and different types of heart disease. And so we had 150 patients who were included who were on dialysis. And about 30% of them had HEF-MREF or HEF-REF, and about 40% of them had HEF-PEF, and 30% of them then had normal structure and function of their LV. And then if you looked at transplant patients, very few of them had HEF-MREF and HEF-REF, but a huge number, 3/4, would meet the criteria for having PEF. And that's consistent with the large studies that you've got from population level data. So I think you can believe the percentages of patients with the different versions of heart failure. Right, on to what I should be talking about. Foundation therapies for heart failure. What am I talking about when I talk about foundation therapies? I'm going to be talking about the ones that are established evidence-based practices or goal-directed medical therapies for heart failure with reduced ejection fraction. And those are beta blockers, ACE inhibitors, angiotensin receptor blockers, or neprilysin inhibitors. The only one of those on the market, as far as I'm aware, certainly in the UK and I think everywhere, is sacubitril valsartan, or Entresto, as you might refer to it. Then aldosterone antagonists, and SGLT2 inhibitors. So there is a huge weight of evidence behind each of these classes of drug for the treatment of whatever we want to call it, and it's changed over the years: chronic heart failure, congestive heart failure, reduced ejection fraction. And there's, for them to have all been written into the guidelines in the way that they have been, there has to have been, and there is, overwhelming evidence for efficacy in terms of mortality benefit, cardiovascular events, hospitalization, for all of those classes of drug. And the heart failure clinicians have done a really, really good job of positioning these drugs as sort of disease-modifying therapies for patients with heart failure. And those trials have all of that in common. They also have in common that they systematically excluded patients with chronic kidney disease, and sometimes chronic kidney disease that wasn't particularly severe. Now, the definitions for exclusion and why they're excluded change over time. So some of these studies are published long before EGFR was a thing. So the beta blocker study I mentioned there talks about severe renal disease. One of the studies talks about a serum creatinine of above 300 millimoles per litre, which I think is about 3.5 milligrams per deciliter in the sort of money that you use. Some of them talk about EGFR more latterly, so DAPA-HF talks about excluding people with EGFRs less than 30. So we don't have good evidence from these studies that we can apply to our advanced CKD and to our end-stage population. And that might partly explain why the prescription of these medicines is not so good. So here is a large study that published, I think, is it in JACC? Yes, in JACC a few years ago, looking at the prescription of these goal-directed medical therapies for heart failure in patients when they were discharged after a heart failure admission to a hospital in North America. There's many sites, 400 and something sites, I think, were included in this. And they looked at the percentage of patients who were on ACEs or ARBs, beta blockers, MRAs, and ARNIs. This is before SGLT2s became a part of standard of care, so they're not included in this. But let's just go through them one at a time. So if we look at the ACE inhibitor group, if you've got normal kidney function, 80% of people are discharged on an ACE inhibitor. That drops off pretty dramatically down to 25% if you're a patient with a GFR less than 30, and is a bit better, which surprised me actually, if you're on dialysis. So about 40% of patients were on an ACE or an ARB if they were on dialysis. Bear in mind that these patients have got CKD. What's one of the most important drugs we have for chronic kidney disease? ACE inhibitors and angiotensin receptor blockers. Again, that speaks to a different problem as to how we manage patients with early stage kidney disease and cardiovascular renal metabolic disease. Prescription of beta blockers was rather better, so 90% if you've got normal kidney function, down to just under 80% if you're on dialysis. Prescription of MRAs was not great in any group, so under 50% if you've got normal kidney function, but only 5% of the dialysis population. And then ARNI use was pretty low as well, but lowest in the dialysis population. So that's where we are in terms of how we're getting patients with end-stage kidney disease onto these types of therapies. And many of you will be sat there going, well, it's because of these reasons. And you're absolutely right. We do have limited trial data to inform our practice in this area. There are concerns with some of these drugs, which are vasoactive, that they're going to affect residual renal function, and residual renal function is incredibly important in terms of prognosis. There are concerns about some of these drugs causing hyperkalemia, which I've spelt in the UK way, so apologies if that's difficult for you to read. There are also concerns about intradialytic hypotension, and we have to balance this up with treatment of blood pressure generally in dialysis patients, and we don't have targets for blood pressure in dialysis patients. Certainly we don't have agreed targets, and that's probably because the targets should be different for different types of patients. And when we're thinking about giving these drugs to people, we do have to think about the unwanted consequences of them. We do have to think about the renal function. We do have to think about potassium, and we do have to think particularly about blood pressure. And I'm just going to refer back to this quote, which is one of my favorite quotes from someone I'm not going to ask you to guess, I'll just show you. But this is a very, very eminent nephrologist who published this work, and this quotation came out of it. This is from the 90s. Failure by the world dialysis community to understand and use the dry weight method of blood pressure control has resulted in an increasing incidence of treatment-resistant hypertension, which remains the principal cause of cardiovascular morbidity and mortality. And that was written by Belding Scribner of Scribner Shunt fame, long before we were talking about goal-directed medical therapies for heart failure. And I think what he's referring to there is this vicious cycle that occurs in dialysis patients. And we can focus this around patients with heart failure or those at risk of heart failure. So all patients on dialysis will either be at risk or, as we know now, 30 to 40% of them will have established heart failure. And they're all at risk of salt and water retention. And salt and water retention drives high blood pressure. It drives hypertension. And you'd be forgiven if you're a primary care physician or you're a keen fellow or you're maybe an earlier stage attending, that the response to high blood pressure in a dialysis patient is to give an antihypertensive agent, because we don't want people with high blood pressure. We want to reduce their risk of stroke. We want to reduce their risk of cardiovascular disease. But one of the problems with giving antihypertensives as our first line in dialysis patients is we are going to cause, in a group of patients, intradialytic hypotension. Now, intradialytic hypotension is awful for patients to have to go through. Going flat is no fun for anybody. It's horrible for dialysis staff to have to deal with. But it also causes this phenomenon, or is associated very strongly with this phenomenon of dialysis-induced myocardial stunning. And dialysis-induced myocardial stunning is one of the key mechanisms that drives heart failure development and progression in dialysis patients. And if we look back at the studies that came out of Derby in the UK, which is literally 40 minutes up the road from where I'm sitting here, done by Chris McIntyre, who's on your side of the pond now, and James Burton, who shares an office with me over there, there's a clear association in these lovely, elegant studies that were done in the late 2000s, looking at the relationship between patients who developed intradialytic hypotension or drops in blood pressure that were asymptomatic, and the development of regional wall motion abnormalities. And here you've got the time course along the bottom. This is sessions of dialysis. And those patients that dropped their blood pressure as they went across dialysis were much more likely to develop regional wall motion abnormalities, evidence of myocardial stunning that associates with rises in troponin, but also associates lower along the line with worse patient survival. So having regional wall motion abnormalities, having myocardial stunning events identified associates with worse survival. It associates with an increased number of cardiovascular events. It associates with increased incidence of developing heart failure. So this is something we really need to avoid. And if we can just pause for a second and think about why that is the case, you've got to think back to your cardiac physiology and your mechanics. So Starling's law will tell us that the myocardium, the left ventricle, will contract to a certain degree based on the stretch of the left ventricle at end diastole. And for most people, that's a consistent volume. So it'll be between 120 and 160 mils of blood in the ventricle, less if you're a lady and less if you're smaller. When you go to dialysis and you have ultrafiltration, throughout the dialysis process, the blood volume contracts, and that's not immediately restored by resolution of the tissue in the interstitium. That takes hours to days to happen. So the blood volume and the end diastolic volume reduces. And the only way then for the heart to maintain cardiac output is to increase chronotropy, assuming that systemic vascular resistance is normal. And if you increase the heart rate, if chronotropy increases, the time at which the coronary arteries are filled is in diastole. So diastole reduces. So we're asking the heart to work harder by beating faster, and we're limiting its blood supply. And that's when you're thinking about these patients who've got perhaps abnormal myocardium in the first place with myocardial fibrosis, and they've got increased areas over which oxygen has to diffuse. We're creating a situation of demand ischemia. And it's that demand ischemia that leads to the myocardial stunning events that will then lead to your adverse patient outcomes. So we need to do everything we can when we're thinking about the treatment of heart failure. Before we even get to thinking about medical therapies, we need to think about limiting these types of problems. So before we get to the medicines, we've got to be, how do I optimize dialysis therapy for my patients? And that is getting the volume status right where we can. It's dealing with intradialytic hypertension. It's reducing the ultrafiltration volume or rate that we are, rate at which we're removing water. It's thinking about any other strategies you can think about to mitigate cardiovascular disease. I know the MyTemp trial has sort of put a cross through lowered dialysis temperature, but there may be some people who would benefit from that still. We can talk about that again another time if you like. It's treating anemia and bone mineral metabolism really well. It's limiting salt intake and getting lifestyle right. And that is reflected in the guidelines for management of heart failure on dialysis. And the one that explains things I think the best is actually the Kadoki guidelines, where it talks, yes, about pharmacotherapy for the dialysis population, but that you need to give consideration to how it will alter intrahemolytic hemodynamics, and that you might need reduced doses of these agents. And then actually the cornerstone, here we are, 6.2c, the cornerstone of management of heart failure is the maintenance of euvolemia. And certainly just leaping in with drugs that are going to lower blood pressure to treat heart failure when we haven't got the volume status right is an absolute recipe for disaster. So what is the evidence then for these foundation therapies in dialysis patients? Well, you'll be pleased to know this won't take too long because there isn't much evidence. We reviewed this last year, well, at the end of 2023 and published in 2024. And there are two nice reviews. I'm including ours as a nice review. There are a couple of nice reviews you might want to look at listed below there. But when we look at beta blockers, there is one pretty small randomized trial. When you look at ACEs and ARBs, there's one moderately sized randomized control trial. There are no trials looking at Entresto in the hemodialysis population. There are two absolutely minuscule trials that really are so small you can't take anything from them. And there are no trials yet in SGLT2 inhibitors. So then you have to think about the observational data. And we'll go through some of these in a bit more detail, but largely the beta blocker observational data is the same as the trial data, which we'll talk about. There's a bit more conflict in the ACE and ARB data. The ARNI data is very much still out there. The MRA data, there's signals for worsened hyperkalemia and maybe hospitalization, but again, we'll have a little look at that. And again, there's no real observational data yet in the SGLT2 inhibitor population. So in the last part of this talk, we will just have a look through some of the key bits of evidence. And apologies if this is death by survival graph analysis, but they all look about the same. So the first trial we'll look at is this Italian trial, which randomized patients to having dialysis patients to receiving carvedilol, which is a cardioselective beta blocker, or placebo. And they showed that there was a survival advantage at 2 years to those receiving carvedilol over those receiving placebo. And there were also important improvements in left ventricular ejection fraction. There were improvements in symptomatology, so NYHA functional class improved in those receiving beta blockade, and there was a reduction in the numbers of patients being hospitalized and for all-cause hospitalization. Now, that all sounds great, and it is good, but the devil is in the detail. And this trial had a run-in period, and it showed that throughout the trial, there were similar sorts of side effects between the groups, but about 14% of the patients who were randomized to the intervention arm, the carvedilol arm, were excluded during the run-in phase because they couldn't tolerate the hypertensive episodes. Some of them got bronchospasm. Some of them developed worsening symptoms of heart failure during that run-in period. And some of them had bradycardias that meant they couldn't stay on the drugs. And those are important things to consider, because whilst the trial data says, yes, beta blockers good, we need to be monitoring and thinking about patients with heart failure who we're starting these drugs on, because there are important side effects that we need to consider. So stack that trial data up against the observational data that exists, and there's a few very big observational studies. I've picked this one by Tang, which is a Taiwanese retrospective propensity score match study, which looked at 3,500 patients, but with follow-up over 10 years. So pretty good follow-up, and it was a well-conducted database study. And it showed quite a consistent effect compared to that trial that I've just shown you, in that beta blocker therapy was associated with a 20% reduction in mortality. So the evidence for beta blockers in dialysis patients is pretty good, I think, if you put that together with the small trial that we have. But we have to consider, as I say, the off-target side effects that might be difficult for patients. What about ACEs and ARBs? Well, the same Italian group a few years later did a larger study, multi-center study this time, looking at the effects of telmisartan on outcomes for patients with heart failure reduced ejection fraction. And again, the results were very encouraging. There was a reduction in all-cause mortality, cardiovascular mortality, and hospitalization. But again, you could just be forgiven for taking away the top lines from that, but there are considerations. The telmisartan group were more likely to discontinue therapy than the placebo group, and the reasons cited for that were an increased frequency of hypertension and won't surprise you to see hyperkalemia. So yes, for patients with REF, if you've got the volume status right, you can think about ARBs, but it's not a fire and forget. We need to be mindful of what the side effects might be and what we need to look out for once we start these therapies. And you stack that up against the observational data, and much of the observational data is consistent with that. So this is again a similar Taiwanese study, similar sorts of propensity score matching for a cohort of patients with HFrEF who are on an ACE or an ARB versus those are not. And again, you get similar sorts of effect sizes in terms of the effects on all-cause mortality and on cardiovascular mortality. But there are some observational studies which didn't find that. So this is a Minnesota heart study, and whilst the graphs here are not the prettiest, shall we say, they did clearly show that whilst there was an effect for benefit in patients not on dialysis, that effect wasn't there in patients on dialysis. So it's slightly conflicting compared to the trial data and not as consistent as the beta blocker data. A key practice point, though, I think, is that whilst the observational studies looked at ACEs and ARBs together, the trial data is in ARBs. And if you look at the dialysability of ACEs and ARBs, ACE inhibitors tend to be dialysable whilst ARBs are not. So if you are going to plump for one of these to treat heart failure, then an ARB would probably be the best, and telmisartan is where the evidence, such as it is, lies. Entresto, there are no randomized controlled trial data published currently on the use of Entresto in dialysis patients. There are some smaller observational studies and some medium-sized observation studies which suggest ARNI use improves left ventricular function. But this study that I've popped up here, published a couple of years ago, was a retrospective subgroup analysis of a multi-center trial which looked at 618 dialysis patients with REF and showed a worrying increase in risk of hospitalization for heart failure in patients on ARNI therapy, and actually an increased risk of death in those patients. Now, this is likely to be driven in part by confounding, and these studies, observational studies, are obviously open to bias, but it's definitely not a clear-cut story coming out that Entresto is going to be the cure-all for heart failure in patients on dialysis. And those of you that have used the drug will know it does have profound hypotensive properties, and maybe that will come out of the trials that are ongoing. So the MRA trial data, as I said, is so small that I'm not going to go through it in any detail because I don't think you can get a lot from it. Trials tended to suggest that left ventricular geometry and ejection fraction improved, but that hyperkalemia was common. The effects on outcomes, if you look at observational studies, are really, really conflicting. Some say that hospitalizations are reduced, sometimes say that mortality is increased. We really don't know. There's not enough high quality data to draw any conclusions yet. But the one thing that is clear is that the risk of hyperkalemia is much higher than it is for ACE inhibitor use or beta blocker use. And that if you are advised to start these drugs in your dialysis patients, it is really worth watching out for. Data for SGLT2 inhibitors, we haven't got any yet, and so I can't tell you anything. So it's a blank screen. You'll be pleased to know we can just move straight on. We will talk a little about it if you like at the end. But there are studies on the horizon, both in patient, both for the use of Entresto and for SGLT2 inhibitors. And some of those studies are very, very small, but some of them, like the Renal Life Cycle trial, which is looking at the effects of DAPA on kidney and cardiovascular outcomes in advanced CKD, they do include patients on dialysis. So we will have some information about those. I don't know if it'll come up in the chat at the moment, but for me, thinking about how an SGLT2 inhibitor will help an anuric dialysis patient, I mean, I am left scratching my head a little bit, but we'll get some evidence, I think, in the coming years, and it might be useful for patients that continue to produce urine. So where does that leave us? I hope I've shown you that it's not easy. I hope I haven't claimed to have all the answers. And actually, I think for most of these people, what we need is a considered multi-professional approach. I work with our heart failure team here closely about lots of these things. And this is the sort of strategy that we've come up with. Is that the first thing we need to be looking at is making sure people are euvolemic. As dialysis doctors or nephrologists, thinking about carvedilol or telmisartan, I think we can be actively doing that ourselves without necessarily needing the sign-off from our cardiology colleagues. Much more caution is needed when using MRAs and ARNI therapy, and for the SGLT2 treatments, so we're really in a black box. We don't know. The other thing that's just worth mentioning is that we do have a bunch of binders now, which are much better than they used to be. And if hyperkalemia is a terrible problem for patients when they're using ACEs and ARBs, we could give consideration to using Lokelma or Patiromer as a binder therapy. Although, again, I will say that is outside of the evidence base at the moment. So when we wrote our sort of review of this last year, we came up with what we hoped would be a useful algorithm in how you might want to approach the management of heart failure with reduced ejection fraction in an end-stage population. And this is what we came up with. So first and foremost, get the patient euvolemic. If you can't do that, think about strategies for helping them achieve euvolemia. Do they need to do longer dialysis, maybe overnight, where you can abrogate the effects of myocardial stunning by reducing the ultrafiltration rate? If you achieve euvolemia, you can go back into here and think about medications like beta blockers and ACE inhibitors. If you can't achieve euvolemia in someone with established heart failure, you can't really just start throwing them onto drugs that are going to affect their blood pressure, because you're just going to end up making the situation worse. And actually, in that group of patients, if you've got established heart failure and you can't render them euvolemic to treat their heart failure properly, then we are talking about supportive management and symptom management in those types of patients, because there's nothing really that you can do to make them better. So if you have got them euvolemic and on these drugs and they're still symptomatic and their ejection fraction is not improving, then I think it's conversations with your cardiology colleagues about whether they think adding in these types of therapies with the correct types of monitoring are useful. And obviously, underpinning all of that is we need the right data. We need to know that the left ventricle is being measured at a time of euvolemia, that the natriuretic peptides are being done when the patients aren't overloaded. So I'm going to stop there and take any questions that you might have. And if I don't know the answers, I will just be honest and say so.
Thanks very much, Matthew. So there's a couple of comments in the chat, and I'm not sure if those folks want to put their hands up and ask the question. If not, I'll ask it later. But I'll maybe start with a question. So one of the things that I see in my general nephrology clinic is patients coming from the cardiologists on multiple of these drugs with, blood pressures of 100 systolic, and, kidney dysfunction, which I think is likely related to renal hypoperfusion. When you look at our dialysis patients and we don't know what the blood pressure should be, and we driving the blood pressure with, volume management, how do we know, how do we add in these therapies? And how do we balance that effect on blood pressure in the dialysis patients when we don't know what it should be anyway, and avoiding the intradialytic hypertension, which we know causes the myocardial stunning, which isn't great for them either. So do you have any guidance for us around that?
Oh gosh. Oh wow. I wish I could tell you definitively. But I think we just need to separate out what we're thinking about the drugs for. So if you look at the trials like HEMO and FOSTER and things, that was looking at affecting structural cardiovascular disease with ACE inhibitors, and they were all negative. So if you've got someone with LVH so what you might now consider to be a PEF phenotype, I don't think there's any evidence for adding in ACE inhibitors and those types of RASi therapies for those group of patients. But when you've got patients with reduced ejection fraction heart failure, if you've got someone with a normal-ish blood pressure and no edema, and they're not suffering the effects of intradialytic hypotension, those are the patients that we need to have a considered approach to actively starting pharmacotherapy in. If we ask all our dialysis patients to open their mouths and we throw valsartan at them, we are just going to end up in a terrible, terrible state. Because again, we talk about syndromes. Dialysis is they're not a group of patients. They're a really heterogeneous bunch of phenotypically different patients, and so it is almost a one-to-one, personalized, thoughtful, considered approach to starting all of these types of treatment. So has that answered your question? Probably not. What was the core of your question? Is there a target we should get? I think we need to sort of work towards the normal blood pressure targets because we don't have a target. So if you can get someone euvolemic and they've got normal blood pressure and they don't have heart failure, I don't think there's evidence for putting people on RASi therapy there or heart failure type therapy there. But if at that point they have reduced ejection fraction heart failure, those are the ones to get the drugs into them.
I think what I'm hearing you say is I see the cardiologist just applying the same treatment principles to everyone, and you're really asking us to be a bit more thoughtful and look at our individual patient phenotype and starting with volume. Yeah. I do have, I think, Peter with his hand up.
Yeah, can't find the hand on Zoom. Maybe an extension of that. Your flow chart included symptoms. Because it seems to me that I have seen lots of people with low ejection fraction who we seem to achieve euvolemia who are not symptomatic of volume overload, but they see a cardiologist, and because their ejection fraction is 30%, they want to start them on a drug. They do start them on a drug, often causing hypotension. And the one that gets me is the dose. So they say, oh, because of hypotension, let's start with 4 milligrams of candesartan or 1.25 milligrams of ramipril or something. And it seems to me all the heart failure trials to my knowledge, all were on full dose ACE or ARB. They were not on tiny dose. So I think
you're so right.
I think they're putting our patients at risk for hypotension with zero likelihood of benefit. And yeah, okay, if they're symptomatic and still short of breath, then you can't fix that with dialysis. I guess maybe you try a drug, but that's often not the case.
No, I completely agree. I agree with everything that you've said there. And the other thing, I think, the reason I think it's important that we as nephrologists take ownership of some of these decisions is because we have an understanding of the plight of our patients and the symptomatology of our patients that the cardiologists don't have. And so they see the syndrome of heart failure, and they see tiredness, and they see muscle wasting, and they think, oh, heart failure, heart failure, heart failure. But we know that CKD is a muscle wasting disease, and that the symptomatology of CKD, independent of cardiac function, is very, very similar. There's lots of overlap. So in terms of the initial decisions about optimizing volume and getting people onto those more evidence-based, if I can call them that, therapies, I think that's our realm. And then if we're going for more advanced type drugs, and certainly, and it's outside of my scope of practice to talk about devices and things, but if we're talking about devices for heart failure, that's when I would be including my cardiology colleagues.
I'm not seeing any other hands up. So you go ahead, Peter. Did you have something else?
You know, as you know, I will always have other questions.
All right,
nobody
go
else
ahead.
does. Maybe you had one. So I also liked your emphasis on the HFrEF versus HFpEF and the lack of evidence for anything very much in HFpEF. One thing I would question is the ACE versus ARB, for instance. You mentioned that ACE inhibitors are dialyzable.
Yeah.
I've always been a big fan of dialyzable drugs given post-dialysis, with the contention that maybe by the end of dialysis, when they're most prone to hypotension, maybe the drug level is lowest and you won't exacerbate the hypotension so much, and then you give them a top-up of drug post-dialysis.
Yeah, I think that's a very sensible strategy, and it certainly it deals. And when we're in an evidence-free zone, you've got to think about physiology and pharmacology and all that sort of stuff, and it fits with all the things we know about how those drugs work when they work. So yeah, I'd be on board with that strategy.
I think that applies to beta blockers too, where you can give water-soluble dialyzable bisoprolol or something else post-dialysis 3 times a week, and there is evidence that it hangs around till the next dialysis, and certainly most people would rather take 3 pills a week of that than 14 pills of carvedilol.
Yeah, I agree with that too. They could take it in the UK with their roxadustat. That's not true, actually. It's only licensed for pre-dialysis patients, but there you go.
Yeah, we aren't using it.
No, we're not using much either.
Just a comment in the chat about the SGLT2, and again, looking at the pharmacology and how we think it works and whether that'll be useful in our anuric patients. So I actually mostly work with transplant patients. So one of the slides that interested me was when you looked at the comparison of the phenotypes of heart failure in transplant versus adrenal disease patients. Do you have time series? Is the change in prevalence between reduced ejection fraction and preserved ejection fraction heart failure in transplant versus end-stage renal disease due to a selection bias of people who go forward for transplant, or is it actually that improvement that you were showing initially of the younger sort of patient changing to a different phenotype?
Yeah, it's a great question. And there's always a selection bias with the transplant patients because they've got to be considered fit enough, which involves sometimes varying degrees of cardiac workup. focusing on relatively unimportant or important aspects, depending on who you speak to. I think the answer to your question is it's sort of bimodal. And after transplantation, you see a regression in some of the pathological features of urinary cardiomyopathy. And if you serially image people over time, there'll be, at a population level, improvements in cardiac function, improvements in cardiac structure. But then time accrued with the transplant, being exposed to effects of calcineurin inhibitors, the metabolic complications that then come. So transplant's another group altogether, because you've got the background of having had end-stage kidney disease and the uremic milieu of that, and then you get all the new metabolic complications of transplantation. So they come up with it's probably going back towards a more classical atheromatous type picture, particularly the ones that develop diabetes. But they are then at risk as time goes on of developing REF. Most of them, as you saw from that bit of unpublished data I showed, most of them have PEF and will be transplanted with PEF. And it's that regression in LV mass and the resolution of cavity size that happens in the first few years, but then you'll develop a different type of heart failure as time goes on.
Mm-hmm. Okay. Thank you. Peter's got one more. Oh my goodness. Go ahead, Peter.
You didn't talk really about arrhythmia, and clearly lots of people with heart failure die arrhythmic deaths. Lots of dialysis patients do, maybe more the hyperkalemic ones. I think there's a contention that beta blockers might be the drug of choice for hypertension or anything else in dialysis patients because they might reduce arrhythmic death. Do you think that's something to think about?
I think it is. So, and certainly from, as you say, when you look at mode of death, fatal arrhythmia is right up there, and that's more prevalent in patients with heart failure. And it's, I think, the sort of mechanistic science and some of the imaging work we've done is supportive of the idea that there's a preponderance of scarring for the interventricular septum, which is obviously where the fibers run for electrical conduction. So if you're interrupting those, you're more likely to develop. I mean, dialysis is a perfect storm for fatal arrhythmia anyway, with the fluid shifts and the electrolyte shift, and you put that together with conduction abnormalities and you're in all sorts of trouble. So it seems sensible and certainly logical that beta blockade that sort of regulates rhythm would be drugs to help abrogate those adverse effects.
Great. Well, thank you very much. It's always nice to have, these very clear walkthrough of the pathophysiology, and then nice, sensible recommendations that take into account not just, the evidence but the clinical challenges that we run into. So really appreciate your taking your time with us, and we hope this is the last big thing you have to do before a fantastic vacation. So enjoy. Thanks.
Thank you very much, Joel. Have a nice day.
Have a good day. Bye.
Bye.